And there is ample evidence from animal experimentation and clinical data that shows that mechanical ventilation with intermittent positive pressure is a very important factor in the development of BPD. The other factor that Dr. Soxat has done a tremendous amount of research over the years is oxidative damage, because we usually have to give higher FiO2 in the inspired gas to these babies. And the other factor that is also associated with a higher risk of BPD is infection, either antenatal related to maternal chorioamnionitis or postnatal. So most of my comments then will be directed to methods to reduce the damage induced by mechanical ventilation in this population of extremely low birth weight infants. Without any doubt, overdistension of the air spaces is one of the main mechanisms of damage in these lungs. Not only because it will produce a risk of interstitial emphysema and pneumothorax that are the most obvious immediate consequences of overdistension, but overdistension will also trigger essentially an inflammatory cascade because of endothelial damage. We have to keep in mind that when we are stretching or overstretching the lung, we are also overstretching the capillaries in the lung. And that produces endothelial damage that ends up with adhesion of polymorphonuclear, activation and release of inflammatory mediators. This overdistension and stress of the capillaries also can increase the permeability of the vessels, leak of protein into the interstitial and alveolar space. This produces surfactant inactivation that leads to low compliance, and we enter then into a vicious cycle where the more we overdistend the lung, the higher the pressures we use, the more damage we induce, and the more pressure we have to use then to achieve ventilation and oxygenation in this baby. So excessive tidal volumes, without any question, is one of the main factors in the pathogenesis of lung injury.